Welcome on behalf of the National Hispanic and Latino Addiction Technology Transfer Center to this four-part learning series on substance use disorders in the Latino population. This learning series is made possible through the funding from SAMHSA, the Substance Abuse and Mental Health Services Administration. Presentation does not necessarily reflect the views, opinions, or policies of the National Latino Behavioral Health Association, the Center for Substance Abuse Treatment, the Center for Substance Abuse Prevention, or the Substance Abuse and Mental Health Services Administration, SAMHSA, at the federal level. Moving forward here, in terms of the mission of the National Latino Behavioral Health Association, and the mission and the goal of the organization is to influence national behavioral health policy, eliminate disparities in funding and access to services, and improve the quality of services and treatment outcomes for Latino populations. The objective is to provide national leadership on mental health and substance abuse concerns of the Latino community. NABLA's policy priorities are the following: target capacity expansion of mental health services for the Latino, Hispanic, Latinx population, Latino behavioral health, evidence-based practices, legislation to increase the number of counselors, therapists, and other behavioral health practitioners in the field, funding for co-occurring disorders of alcohol and substance use disorders, opioid crisis in the Latino community, and suicide prevention. Our executive director is Frederick Sandoval, and you see his picture here. Next, I just want to draw your attention to the fact that we have technology transfer centers across the country in different areas, in prevention, in addiction, and in mental health. And this map shows you where they are located. We want to encourage you to go to the website for the TTCs and learn more about the training, capacity building, technical assistance services that are available to you across the country in different specialty areas. In terms of the mission for the National Hispanic and Latino Addiction Technology Transfer Center, it is the mission of the National Hispanic and Latino ATTC to provide high quality training and technical assistance to improve the capacity of the workforce serving Hispanic and Latino communities in behavioral health treatment, as well as recovery. We disseminate and support the implementation of evidence-based and promising practices to enhance service delivery, promote the growth of a diverse, culturally competent workforce, and bridge access to quality behavioral health services. We are committed to increasing health equity and access to effective culturally and linguistically grounded approaches in our work. You see here, at the very least, 2 staff people who work at the Hispanic and Latino National Addiction Technology Transfer Center. Dr. Susie Villalobos is the director for both the National Hispanic and Latino ATTC, as well as the Prevention Technology Transfer Center. Ana Chavez Mancillas is the program specialist for the National and Hispanic Addiction Technology Transfer Center. We encourage you to read more about their bios and to get in contact with the National and Hispanic ATTC as well as the PTTC. In terms of today's presentation, it will be done by me. I will give you a little bit more about who I am and what I do. My name is Jaime Hernandez, and I am director of the Latino Addiction Counselor Education Program here in Massachusetts. I am originally from Puerto Rico, but I practice here in Massachusetts and in other parts of the country. I have 34 and a half years of practice in our field of mental health and substance use disorders, with a very specific focus on eliminating disparities and building equity And I am committed to working within systems to create meaningful access to our folks. I have a lot of letters after my name. I'm a certified prevention specialist. I'm certified and licensed as an addictions counselor at the reciprocal level. And I have a PhD, but you should also know that I have a GED. And my GED I got in prison. And it was more challenging to get a GED in prison than to get a PhD out here. I am a person in long-term recovery from substance use disorders and mental health challenges. And for me, that means that I haven't used a drug, including alcohol, for the last 35 and a half years. That enables me to be a productive member of my familia, first and foremost, to be able to do the work that I do at the community level, and to be a productive member of society. So that's a little bit about me. I'm going to come at this from a couple of perspectives. So our first module is on alcohol and substance use disorders, and we're going to talk about screening and treatment as well. So the perspectives that I'll come at this with is what does research says, what does the data say about this topic area, and I will also pepper that with some lived experience in the field. The course outline, as you can see, I've already talked about Module 1 being the focus of alcohol and substance use screening and treatment. Module 2 will be about tobacco, again, substance use screening and treatment. Module 3 will be about opioids, and Module 4 will be about stimulants. So we look forward to having you go through all of the modules and to encourage you to encourage others to take part in this as well. So in Module 1, we're going to do an introduction to substance use disorders in the Latino population. We're going to dive into alcohol use within the Latino, Hispanic, or Latinx population. And then we're going to talk about screening and treatment for alcohol use disorder in Latino population. So that is basically the outline that we're working from. We know that the DSM-5, the Diagnostic and Statistical Manual of Mental Health, Mental Disorders, it's in its 5th edition. It defines substance use disorders as a constellation of behaviors involved in compulsive drug seeking, including impaired control of substance use, impaired social interactions with others because of the substance use. And this includes interactions with family, work, friends, that sort of thing. Risky drug use, examples here include substance use in hazardous settings for people. And then pharmacological changes. Examples here includes experiencing withdrawal symptoms. So we know that that's the definition within the DSM-5, and we'd like for you to keep that in mind as we move forward. The factors that determine substance use and addiction are multifactorial. So there's not one thing, there's many different things. When we look at public health very specifically, in the US, the pattern of use changes according to geographical area, right? Well, and we know that while available across the country, methamphetamine availability is higher in the western part and the Midwestern regions of the US. More than 70% of local law enforcement agencies from the Pacific and West Central regions of the US report methamphetamine as the greatest drug threat in their area. As we talk about opioids and other drugs, we just need to know that there are regional differences as it relates to what's going on. There's a lot of similarities as well. In terms of epidemiological focus and patterns, where in addition to the geographical differences that I talked about, legal, ethnic, cultural, and socioeconomic factors influence the development and progression of substance use disorders and addiction. The Latino, Hispanic, Latinx population, these are people of Latin American origin or descent. These populations living in the US have been, like all other ethnic groups, affected by substance use disorders and the health crisis that we're living through now, and that we've been living through, quite frankly, for a while. In terms of substances, substance use disorder, we know, is a public health issue that has global proportions with significant social economic implications in the communities that are affected. The prevalence of substance use disorders is expected to continue to increase, unfortunately. The most misused substances include alcohol, nicotine, marijuana, cocaine, and opioids. Again, bear in mind the regional differences here. In terms of rates of illicit drug use, it's important to point out that historically, overall rates of illicit drug use in the Latino Hispanic populations have been lower than those of whites and blacks. That's an important piece of information for us to understand. Upon closer examination of substance misuse prevalence within segments of the Latino population, this yields findings that differ regarding a variety of indicators. This includes country of origin, immigration status, gender, and age, to name a few, right? So, for example, studies have long demonstrated that substance use rates are generally higher for the US-born Latino population than for immigrants, and that these differences may manifest differently in ethnic subgroups, right? So we cannot afford to paint with a broad brush, thinking that substance use disorders affect all Latinos in the same way. There are differences that are important for us to bear in mind. Here is a question to consider. Do you believe that people with substance use disorders should have the option to be treated while incarcerated? We know that the US has the largest prison population per capita in the world, and we know that Native people, African American people, and Latino Hispanic people are overrepresented in the data of incarceration in the US. And we know that some studies point to the fact that, depending on who you read, approximately 65% of people who are incarcerated have an active substance use disorder. This has implications for policy, for practice, for what we do. And I'm hoping that when you consider this question, you're saying yes, that we should treat people with substance use disorders who are in prison, because we want to address recidivism rates. In other words, we want to reduce the number of people who go back to prison over and over and over again. And unless we treat the underlying issues that they're dealing with, which include mental health and substance use disorders, people end up going back constantly, right? So to get straight into it, right? That was sort of the laying the context for what's to follow, with this focus on alcohol use disorder as the first module. We know that there are gender and age differences as it relates to alcohol use disorder. For example, binge drinking. In terms of the 2014 National Survey on Drug Use and Health, and those findings, they showed that the rates of previously 30-day binge and heavy drinking were highest among American, Indian, Alaskan natives, and lowest amongst Asian Americans. We know that from that study. In terms of prevalence of lifetime alcohol use disorder, it has been reported to be also highest amongst American, Indian, Alaskan natives, and lowest amongst Asian Americans, Pacific Islanders, and was approximately 10% higher for whites than for blacks and Hispanics. So this is, again, some grounding data regarding binge drinking and prevalence of alcohol use disorders. For the Latino population and alcohol use disorder, we must understand that Latinos from different national origins, as I alluded to earlier, have shown differences in the pattern of alcohol use. For example, Mexican Americans had the highest prevalence of alcohol dependence, volume of consumption, and youngest age of first drink compared to Puerto Ricans, Cuban Americans, Central and South Americans. This has implications for how we plan prevention, intervention, treatment, the multiple pathways of recovery, and recovery supports. Odds of alcohol dependence were nearly 4 times greater among Hispanics with major depressive disorder compared to Hispanics who did not meet the criteria for major depressive disorder. this speaks to the issue of co-occurring disorders, right? Again, we must have comprehensive understanding of what's happening on the ground for folks. In terms of acculturation on alcohol use disorder, when we're thinking about the Latino population, right? Research findings on these issues show us the following. Puerto Ricans, Cuban Americans, Mexican Americans, and South and Central Americans have not shown an association between acculturation and volume of drinking, binge drinking, or drinking 12 or more drinks in a single day amongst men, very specifically, right? Now, we know that there's such a thing as acculturation stress. So we know that acculturation stress was associated with drinking 12 or more drinks in a day amongst men, Latino, Hispanic, Latinx men. Among women, high acculturation was associated with a higher volume of drinking, and it is also impacted the overall group rate, increasing the likelihood of binge drinking, again, here specifically amongst women. Alcohol use in the last 12 months amongst Latinos, in terms of heterogeneity, Hispanic national group heterogeneity is also reflected in rates of alcohol use in the last 12 months, varying from 1.8 for Cuban Americans to 5.6 for Mexican Americans amongst men specifically, and from 0.2% Central and South Americans to 1.1 for Cuban Americans amongst women, very specifically. And then alcohol misuse. 12-month rates for alcohol misuse amongst men vary 5.3% for Cuban Americans to 15.3% for Puerto Ricans. And amongst women, the rates range from 0.8% for South and Central Americans to 6.4% for Puerto Ricans. So we see disparities in these data in terms of alcohol misuse. And it's important, once again, to draw attention to the different Latino subgroups and what we've learned by way of research in alcohol misuse and what's going on the ground. We're going to focus now on females and males and how the two genders metabolize alcohol differently. And we know this for years that this has been true for many other populations as well. So when we look at females and alcohol use in pregnancy poses specific risk to the developing fetus, and it's linked with adverse perinatal outcomes, which are likely more common than previously reported. And it's important to know that half of all pregnancies in the US are unintended, right? That has implications for what we're talking about. A fetus may be exposed to alcohol in utero at important times and in embryonic development, even before the woman knows that she is pregnant. Again, implications for what we do with women specifically. Alcohol use during pregnancy is a leading preventable cause of birth defects and developmental disabilities in the US, with fatal alcohol syndrome being one of the most severe outcomes. Emphasis on this is preventable, right, when we think about these things. Other adverse health effects associated with alcohol use in pregnancy include miscarriage, preterm labor, in-uterine growth restriction, and stillbirth. All of these add morbidity to any potential underlying disability. Alcohol use in reproductive age women and in pregnancy more specifically remains a public health priority in the US and abroad. Obviously here we're focusing in on Latino, Hispanic, Latinx females. And so bear in mind those cultural characteristics as well. When we think about the etiology of alcohol use disorders and the social cultural factors, it is important to understand that alcohol is the most misused substance worldwide, right? Highest consumption in terms of alcohol in, as you can see here, in France, Spain, and Italy, where consumption of alcohol is widely accepted. Men consume more alcohol than women, but differences may vary by country. In Israel, very specifically, men drank 3 times as much as women. In the Netherlands, men drank 1.5 times as much as women. Availability impacts usage, right? Usage is higher when alcohol and drugs are easily available. In 2003, drug use among youth who had been approached by drug dealers was 35%, compared to just under 7% amongst youth who had not been approached. I want you to also think about how communities are organized and what they look like on the ground, particularly poor and working class communities, and the availability of drugs and alcohol on the ground for folks, and the impacts that that has on folks. More on the etiology, there are family factors, so parental alcohol use has an impact, marital discord, psychiatric or legal problems in the family linked to substance use, lack of emotional support from parents has been reported to increase use of cigarettes, marijuana, and alcohol. And then lack of parental monitoring linked to higher drug usage. And we know that many folks in our families work, and so kids come home and there might be a lack of parental supervision during those times for young people, having an impact on what we're talking about. More on the etiology of alcohol-related disorders, and again, the social cultural factors here. In terms of social networks, social influence or social selection is the question, right? Research shows that there's evidence for both. Having peers who drink influences drinking behavior, so that's the social influence. But individuals also choose friends with drinking patterns similar to their own, and that is social selection. Again, this has implications for working with people across the continuum, from prevention to intervention, the treatment to the multiple pathways of recovery and recovery supports. And then we see advertising and media. Countries that ban ads have 16% less consumption than those who do not, those countries that do not. We know that there are policies in the US around advertising and media, but we know that there isn't an outright ban on advertising. And we see disproportionate number of ads that are targeted to people of color, including Latino, Hispanic communities across the US. So we transition here to screening and treatment of alcohol use disorder in Latino populations, right? And so some of the screening tools that are available for folks around alcohol use disorder include the following: alcohol use disorders identification test, and it's called the audit, screening and behavioral health counseling interventions, adult substance use surveys, the ASUS, and then the TWEAK, which means tolerance, that's the T. For the W, it's worried. For the E is eye-opener. The A is amnesia. And then the K is attempting to cut down. So these are some of the screening tools that are available to us when working with people who have alcohol use disorder. A tool that is widely used in the substance use disorder world, including for alcohol, is the CAGE. It's a screening technique and a tool that is used. The CAGE is very brief screening technique. It's probably the most widely used, as I mentioned before, and it's promoted for the detection of alcohol problems in the US and in other countries, I should add. It's a series of 4 questions that doctors or other practitioners and providers, recovery coaches, nurses, counselors, clinicians can all use to check for signs of possible alcohol dependence. And it is one of the screening tools mostly consistently used amongst medical professionals to identify individuals who have a substance use disorder. So the patient is asked if he, she, or they has ever tried to cut down their alcohol use or drug use. Have they been annoyed by criticism of alcohol drug use? So this is that portion of cut down, annoyed, guilty, eye opener, that sort of thing. The CAGE is a simple screening questionnaire to identify potential problems with alcohol. And once again, it's 4 questions. 2 yes responses are considered positive for males, and 1 yes response is considered positive for females. If you're not familiar with the CAGE, we encourage you to take a look at it. In terms of drugs or medications that are approved by the FDA for alcohol addiction treatment, we see them here: Antibuse, Campral, Rivia, Vivitrol, Wellbutrin, and Zyban. These are all been approved and are in use for alcohol use disorder. Naltrexone is a medication approved by the FDA and the administration to treat both alcohol use disorder and opioid use disorder. Naltrexone is more and more people are becoming familiar with it. It is a morphine derivative that acts as a competitive and antagonist at opioid receptors, and you see what the receptors are there. Naltrexone can either displace opioid agonists from binding at these receptors or prevent opioid binding. So blockade of opioid receptors by naltrexone is a competitive phenomenon and results in elimination of euphoric effect of opioids. And again, it's also being used to treat alcohol use disorder. So to come to the end, here's what we learned from the first module, and here's the summary. We know that the DSM-5 defines substance use as a constellation of behaviors involved in compulsive drug seeking, including impaired control of substance use, impaired social interactions, family, friends, places of employment, that sort of thing, and risky drug use, substance use in hazardous settings, and then the pharmacological changes, more specifically withdrawal symptoms. The prevalence of substance use disorder is expected to continue increasing in the US, unfortunately. The most misused substances include alcohol, nicotine, marijuana, cocaine, and opioids. We know that opioids is in the news constantly these days. And we know that the CAGE, which is a very brief screening technique, and it's probably the most widely used and promoted for the detection of alcohol problems in the US. So we encourage you to take this knowledge and turn it into practice at your local organization, wherever it is that you practice helping people with alcohol use disorder as well as with substance use disorders. So I want to thank you very much for your attendance, for your participation on behalf of the Hispanic and Latino Addiction Technology Transfer Center. We hope that you utilize this information moving forward. So thank you very much, and we hope to see you at the next module, Module 2.